In this video, we are going to talk about adrenergic agonists, the drugs which enhance sympathetic activity, right? If you remember sympathetic, flight or fight, right? So let's review the sympathetic nervous system, right? So the sympathetic nervous system is a section of the autonomic nervous system, right? It's concerned with what? Fight or flight. Right, so it is first order neurons and second order. First order usually found in the thoracolumbar segment here from T1 to T12, including L1, L2, L3. That's the first order. The second order is found like in paravertebral ganglia, or the sympathetic trunk, or the sympathetic chain. Right, so sympathetic nervous system uses a neurotransmitter called norepinephrine, usually abbreviated as NE. It's also known as noradrenaline, right? And you can see its structure there if you need to know it, right? So there is another thing, epinephrine, norepinephrine, right? So norepinephrine is a neurotransmitter, whereas epinephrine is a hormone released by the suprarenal gland or the adrenal gland. Adrenaline. So if you look here, you will see the activity of epinephrine as a hormone and norepinephrine as a neurotransmitter. All right, firstly, you have the first neuron is cholinergic here, and then releasing acetylcholine to the second neuron in the adrenal medulla, releasing epinephrine, right? So epinephrine is a hormone with systemic action, right? It's released directly into blood. If you look here, the first order again is cholinergic, but the second neuron here, adrenergic, and it is local action, and what it releases is norepinephrine, right? Norepinephrine or noradrenaline, right? Next, we need to review the synthesis of norepinephrine. So as you can see here, norepinephrine is being synthesized in the presynaptic knob, right? Presynaptic part of the neuron. Is usually destroyed there by monoamine oxidase, right? Monoamine oxidase, and if it is released into the synaptic cleft, it is activity on the postsynaptic membrane. You can see here adrenergic receptors, alpha-1, alpha-2, and beta, like all of them. You can also see its activity on the presynaptic membrane, right? This is postsynaptic and this is presynaptic membrane, right? So in the synaptic gap here, about 20% of norepinephrine is degraded by catechol or methyltransferase, COMT, this enzyme, and another 80% will be taken up by a norepinephrine transporter here. There will be reuptake. So next, we need to review the adrenergic receptors. We covered these in great detail, right? So adrenergic receptors are classified into alpha and beta adrenoreceptors, right? Alpha will be alpha-1 and alpha-2. Alpha-1, right? This one, remember, is GQ, the smooth muscle contraction. So if you stimulate alpha-1, they will increase contraction of vascular smooth muscles, pupillary dilator muscle, the sphincter muscles of the bladder and intestine, right? You don't need to pee when you are fighting or when you are running, right? Then alpha-2, if you stimulate alpha-2, remember this is a G inhibitor, right? So it will inhibit adrenergic activation, it will inhibit insulin release in the pancreas, inhibit lipolysis in the adipose tissue, production of aqueous humor in the ciliary body, and it induces platelet aggregation. Beta-adrenergic receptors, we have beta 1, beta 2, and beta 3, right? And all of them, they use a G stimulatory. But just remember, G stimulatory in beta 2 will cause smooth muscle relaxation, right? So let's go through what happens. Beta 1, mainly found in the heart, they increase heart rate, cardiac output, contractility, secretion of renin, because the JG cells in the kidney have beta 1 receptors, and also lipolysis. Beta 2, right? So if you stimulate beta 2, they will increase vasodilation and perfusion, because I said beta 2 is smooth muscle relaxation, right? Also increase lipolysis, increase insulin secretion, glycogenolysis, production of aqueous humor fluid, and it causes hypokalemia, right? It increases the uptake of potassium into the cell, right? Leaving the blood with low potassium, right? It also decrease smooth muscle tone of bronchi, causing bronchodilation, and in uterus, stocholysis. Then beta 3, I said you don't need to worry much about this, right? So the stimulation of beta 3 will increase lipolysis, thermogenesis in the skeletal muscle, and a smooth muscle relaxation in the blood. This is the part you need to remember. Smooth muscle relaxation in the blood. You need to remember this. I will remind you when we get there, right? So now let's talk about adrenergic agonists, right? So these drugs can be categorized as either direct or indirect, right? Direct agonists bind to receptor, whereas the indirect agonist will increase the endogenous neurotransmitter activity, right? So let's start with the direct agonist, right? So the first one is epinephrine, obviously, and this epinephrine, it acts on alpha 1, alpha 2, beta 1, beta 2, right? All of them is non-selective. There is norepinephrine, it acts on alpha 1, alpha 2, beta 1, with a decreased activity in beta 2. Phenylephrine is actually selective, it acts on alpha 1. Then you have alpha 2, right? Alpha 2 agonists. They include clonidine, brimonidine, nafazoline, oxymetazoline, xylometazoline, right? So these ones are selective. Then you have beta 2. Selective beta 2, they include phenterol, salbutamol, terbutaline, salmeterol, formoterol, indacaterol, right? So they have high activity on beta 2, but little activity on beta 1, right? Okay, so let's talk about these one by one, starting with adrenaline, right? That's epinephrine, right? So this is a catecholamine. It's a hormone from adrenal medulla. It is administered subcutaneously, in rare cases via IV, and intracardially in cardiac arrest, or tropically. This drug is destroyed in the GI tract. That is why it is not administered orally, right? No oral administration, because it's destroyed in the GIT. It does not penetrate the central nervous system. It's biotransformed by enzymes in the blood, and it acts during 15 minutes in the internal organs and during 30 minutes on metabolic processes, right? This drug, again, it acts by stimulating all types of adrenal receptors. This drug increases automaticity, conductivity, and contractility of the heart. It causes elevation of blood pressure, bronchodilation, increase in glucose concentration in the blood, inhibition of allergy, and it causes mydriasis. So the indications include anaphylactic shock, asthma, shock or collapse, pupil dilation, open-angle glaucoma, prolongation of local anesthesia, and is also used in acute inflammation of mucous membrane of the nose or of the eye. Side effects include excitement, tremors, hypertension because it increases blood pressure, arrhythmias, and hyperglycemia because it increases processes like glycogenolysis and gluconeogenesis, the processes which increases glucose in blood. This drug is contraindicated in hypertension, in severe atherosclerosis, arrhythmias, in diabetes mellitus, and in hyperthyroidism. The next one is noradrenaline or norepinephrine, right? So this is a catecholamine. It has non-selective action on adrenoreceptors with a preferable action on alpha-adrenoreceptors. Is administered only via IV infusion. It may cause vasoconstriction and necrosis of soft tissue if administered subcutaneously or intramuscularly. This drug increases blood pressure and it causes decrease in heart rate, thus reflex bradycardia, because its alpha-1 agonism outweighs direct beta-1 chronotropic action, right? Therefore, there will be decreased cardiac output. It's indicated in collapse, acute hypotension, septic shock. Is contraindicated in blood loss if there is severe bleeding, cardiogenic shock, and long-lasting shock. The next drug is phenylephrine, right? Phenylephrine or mesotone, right? This drug is a non-catecholamine. It has a selective action on alpha-1 adrenoreceptors. It may be taken orally, subcutaneously, intramuscularly, IV, or tropically. This drug increases blood pressure by vasoconstriction, right? It is a vasoconstrictive action. And it also decreases heart rate and cardiac output. Indications. This drug is indicated in case of low blood pressure, that's hypertension, because it's a vasoconstrictor. It's also used in ocular procedures, right? During those procedures, you need mydriasis, right? So it has a mydriatic action. It's also used in rhinitis as a decongestion. It's very important. It also reduces edema of nasal mucosa and is used in ischemic priapism. This drug is very important in hypovolemic shock and distributive shock, right? Because it increases the systemic vascular resistance. The next group are sympathetics, particularly the alpha-2 agonists, right? First one is alpha-methyl-dopa, right? This one is used in hypertension during pregnancy, and its side effects include direct Coombs positive hemolysis, drug-induced lupus, and hyperprolactinemia. Next, this drug is indicated it causes like a relief of spasticity, and we use it in hypertension. Its side effects include weakness and xerostomia, that's dry mouth. The most important drug in this group, alpha-1 agonist, that I want you to remember is clonidine, right? So clonidine is a lipophilic ring which allows it to cross the blood-brain barrier. This drug is used in hypertensive agency, in attention deficit hyperactivity disorder, ADHD, Tourette syndrome, and is also used as like symptomatic control in opioid withdrawal. And because it crossed the blood-brain barrier, it causes central nervous system depression, bradycardia, hypotension, respiratory depression, meiosis, and it can also cause hypertension with abrupt cessation. The next one is Dobutamine, right? Dobutamine, we will talk more about it in cardiovascular drugs, right? This drug is a non-glycoside ionotropic agent. It's similar to dopamine by its chemical structure. It's administered by IV infusion. It is selective agonist of beta-1 adrenal receptors in the heart. It has a positive ionotropic action. It improves coronary circulation, reduces peripheral resistance. It redistributes blood flow in favor of the heart and lungs, increases renal blood flow, and it does not act on heart rate, and so it does not cause hypertension. Dobutamine is indicated in acute heart failure and cardiogenic shock, right? The side effects, this drug may cause tachycardia and arrhythmias. The next group, albuterol, salmeterol, tebutalin, right? So these drugs are used in respiratory system, right? So they have more activity on beta 2 than beta 1. Right? They increase heart rate, right? It's little effect. Albuterol is used for acute asthma or COPD. Salmeterol for serial, that's long-term asthma or COPD. Tebutalin is used for acute bronchospasm in asthma and tocolysis, right? So mainly they are used like as inhalation, albuterol and salmeterol, right? Tebutalin can be used like in form of tablets. There are other drugs which I just want to mention so that when you meet them, you can remember them in an exam, right? Dopamine. Dopamine usually acts on D1 and D2 receptors, but it can also act on beta and alpha adrenal receptors. It's used in unstable bradycardia and shock. This drug, dopamine, has ionotropic and chronotropic effects at lower doses via beta activity. And it has a vasoconstriction effect at higher doses via alpha activity. The next one is phenoldopa. This one is D1 activity, is used in post-operative hypertension and hypertensive crisis. It's also used as a vasodilator in arteries like coronary arteries, peripheral renal, and splanchnic arteries. It promotes natriuresis. This drug can cause hypotension, tachycardia, flushing, and headaches. The next drug is isoproterenol. This drug has equal activity in beta 1 and beta 2. It has very important hemodynamic effects. It decreases blood pressure by vasodilation, but on the heart, it increases heart rate, thereby increasing cardiac output. This drug is used in electrophysiologic evaluation of tachyarrhythmias. It can worsen ischemia, and it has negligible alpha effects. The next drug is midodrine or midodrine, right? This drug has alpha-1 activity, right? It's important in hemodynamics because it's more like an opposite of isoproterenol, right? It increases blood pressure by vasoconstriction. If you compare with this one, it decreases blood pressure by vasodilation. Midodrine also decreases heart rate and cardiac output, whereas isoproterenol have an opposite effect. Midodrine is indicated in autonomic insufficiency and postural hypotension. This drug may exacerbate supine hypertension. The last drug that I would like to mention is mirabegron. This drug acts on beta 3, right? So if you put a mira on 3, it will look like an E, capital letter E. So you think of mirabegron. This drug is used in urinary agents or incontinence or in overactive bladder. So that is all about direct agonists. Indirect agonists have different activity, right? So they can either inhibit like destruction of norepinephrine, thus enhancing the release of norepinephrine, or they can inhibit a reuptake, right? They can inhibit reuptake by norepinephrine transporter here. All right, so these are some of the drugs here. First one, you have indirect mimetic, right? They promote release. These drugs include ephedrine, tyramine, amphetamine, methylene dioxyamphetamine, and then inhibitors of reuptake. These include atomoxetine, desipramine, reboxetine, right? Reboxetine is very important. It's usually used as an antidepressant. Methylphenidate and cocaine, right? But if you look at cocaine, it has like effect on norepinephrine, dopamine, and serotonin. It increases concentration of all of these, right? And if you look at methylphenidate will increase norepinephrine and dopamine. If you look at reboxetine only act on norepinephrine. It only increases norepinephrine. Methylene dioxyamphetamine, it increases everything again, just like cocaine. Amphetamine, norepinephrine, and dopamine. Ephedrine and tyramine, they only increase norepinephrine, right? So you can see the effects. If there is increased norepinephrine, there will be decreased appetite, increased the drive, increasing blood pressure and heart rate, thus tachycardia, right? Increase in dopamine will increase activity, drive, and there is a risk of dependence, right? So if any drug is increasing dopamine, you can see here what can cause dependence: amphetamines, methylphenidate, cocaine, right? If any drug is increasing serotonin, high doses will cause psychosis. So you can see methylene dioxyamphetamine, it can cause psychosis, and also cocaine, right? Okay, so let's talk about them one by one, starting with ephedrine. Right, so ephedrine is actually not a catecholamine, but it's an alkaloid from Ephedra equisetica. It's administered orally, subcutaneously, intramuscularly, or intravenously, and also topically. It's absorbed in the GIT, metabolized in the liver, and excreted in the kidney. This drug is an indirect general agonist, right? And it releases stored catecholamines. Thus, its activity. It releases stored catecholamines. This drug is indicated in nasal congestion, urinary incontinence, and hypotension. Next, amphetamines, right? So amphetamine is an indirect general agonist. As I said, it's a reuptake inhibitor. It also releases stored catecholamines. It's used in narcolepsy, obesity, and ADHD, right? Narcolepsy and ADHD being the main ones. So you can see Adderall here. It's a controlled substance together with cocaine, which is also a reuptake inhibitor. This drug, cocaine, it causes vasoconstriction and local anesthesia. So if we are suspecting cocaine intoxication, we shouldn't give beta blockers to these patients because it will cause unopposed alpha-1 activation, which will increase blood pressure and coronary vasospasms. Right? Cocaine is usually being abused these days, right? But historically, it has been used to confirm Horner syndrome, right? It causes mydriasis in eyes with intact sympathetic innervation, right? It's used to confirm Horner syndrome. Right, so if you look here, I said norepinephrine is synthesized from tyrosine, right? So you can see the pathway of synthesis of norepinephrine, right? So there are some specific areas where we can inhibit, right? Cocaine, tricyclic antidepressants, amphetamines, you can see them, they inhibit reuptake here. And they also stimulate like a release of stored catecholamines. If you look here, norepinephrine, it acts back like it has a negative feedback, right? So if it is high here, it can act on alpha 2, which is on the presynaptic membrane, inhibiting the release. If you look here, you can see angiotensin 2 is stimulating the release of norepinephrine, right? And fusion of the synaptic vesicle with the presynaptic membrane is enhanced by the presence of calcium, right? And recepin, you can see it inhibit like the entrance of of dopamine into the synaptic vesicle, right? It inhibits the VMAT. Thank you so much. If you like this video, please make sure you give it a thumbs up and don't forget to subscribe. Thank you for supporting me.